Good afternoon. Welcome to the 8th Vulnerable Patient Symposium. It's been a long journey since the first VP meeting here in Orlando, March 2001, where we had our first dinner event with a very small number of colleagues who were focused on vulnerable plaque. Jim Muller remembers that because he opened the meeting. Erling Falk followed with his presentation of misnomer vulnerable plaque and brought two bottles of candies, and the other one was supposed to be toxic, and argued how could vulnerable plaque, which one is vulnerable plaque, and how could we define vulnerable plaque. This was a fascinating meeting in the eve of March, I don't even remember the day, but March 2001. We have come a long way since then. The first VP meeting was about finding vulnerable plaque with temperature, with near-infrared spectroscopy signature, with ultrasound, and else. Ever since, we have held, thanks to pioneers and leaders who lended their support and their guidance to this effort, a grassroots effort. We've had 8 symposia. Through this 8 symposia, we have evolved the concept of vulnerable plaque to where we are vulnerable patient, where multiple components of vulnerability contributes to what we're focusing on as heart attack, acute coronary syndrome, and sudden cardiac death. I want to be very brief here that this journey of 4 years of brain storming and intellectual development has been very productive and promising. The very last meeting, which was not counted in this 8, was a focus group meeting last year, August, in Santa Monica, California, with a group of very thought leaders in the field who had the time to participate in this focus group. And our goal was to come up with a guideline based on what we have learned to approach the concept of screening. And we all know we can't do screening for vulnerable plaque in cath lab for everybody. It was so obvious. And the technique must have been outside of hospital cath lab and invasive procedures. So this is a very brief summary of what we discussed there. How do we go about finding the vulnerable patient? This is the topic of today. I would like to summarize what we have discussed in a very simplified slide that Dr. P.K. Shah put together. The committee, the group that has gone through several iterations of this thought believe that we do need to be cost conscious. And to be cost conscious, we recognize the very low risk group, which is defined based on cholesterol less than 20/80 for heart disease, no diabetes, smoking, as very low risk group. Unfortunately, this population in the United States is less than 10%, and some claim less than 3%. If you consider all of the above. You are about the first step of SHAPE, which is test for atherosclerosis. I don't want to go into detail. Based on those, you follow a guideline. What is unique about SHAPE and this guideline? Dr. Falk will go through detail, but in one line is we are trying to learn from what has been learned in the cancer arena. You have screening for disease, not for risk factors. You are not screening for risk factors of cervical cancer. You're screening for presence of disease in cervical cancer. You're not screening for risk factor of breast cancer. You're screening for a mass in breast. We need to screen for subclinical coronary disease before it becomes clinical. That is the unique part of SHAPE, and we will go into details as Erling presents. I'd like to stop here and invite our first speaker who really inspired all of these efforts, the vulnerable plaque field. Dr. Fusser actually 4 years ago got the first vulnerable plaque award But Dr. Fuster has not been the main center of our brainstorming recently. We invited him late. He has been watching me and has had his hand on my back for the past 2 years. But just the past week or so, I had a chance to go through these thoughts, and we invited his comments, and we very much appreciate his time sharing with us his thoughts.